So we'll move on to the next section, which is on facial nerve. Do you want to talk about the anatomy here? You've already alluded to the digastric muscle being used as a landmark for the facial.
Yeah, glad to. So as the facial nerve goes inferiorly along the vertical segment, some people will stay kind of on that plane, and some people work a little bit laterally. So something to think about when you're drilling. As you move inferiorly, the facial nerve will go to the level of the digastric muscle as it's in the posterior belly digastric, as it's in the temporal bone. They'll come together and they fuse. There's these reflections of periosteum off of the digastric groove that comes up to the facial nerve. When we think about the stylomastoid foramen, you want to think about, like, everyone wants to think it's like Netter, where you have a little hole and the nerve comes cleanly through it. In actuality, there's investing periosteum and the digastric muscle goes into it too. And so it's this really kind of indistinct area of anatomy as it exits. And so if you're doing a facial nerve mobilization or you're following the nerve out of the stylomastoid foramen, you don't want to dissect immediately on the nerve or you're going to hurt it. You leave a little cuff of this white tissue all the way around it as it kind of fans out. But you can follow that digastric muscle anteriorly and it will come to the same level of the facial nerve. I want to draw a parallel to some of the kind of anatomical references that we talk about in head and neck surgery for prostatectomy. And now you can see the same anatomy from the inside instead of the outside. It's the same thing, just looking on the other side of the bone. But prostatectomy, during prostatectomy, people will often say you can follow the facial nerve and it's at the level of the digastric as it comes up. And that makes sense because inside the temporal bone, it's going into the facial nerve and the posterior belly digastric are coming together. We always talk about the tympanomastoid suture line for prostatectomy as well. So you take your finger and you can push, you can see where the mastoid touches the tympanic ring and you can follow that medially and that will point to your facial nerve. You also have the tympanomastoid suture on the other side. You have it in the ear canal, but it's on the same thing. It's just on the other side of the anatomy, but it all tells you kind of where, it kind of gives you a different way to think about the anatomy from the other view. When you're thinking about facial nerve anatomy, we don't really do mobilizations much anymore, but broadly, there's 3 types of facial nerve mobilizations that can be done or have been done. Most of the time, they're for access to the jugular foramen. The jugular foramen and the jugular bulb is located inferiorly, basically centered on where the facial nerve is in the vertical segment. So pathologies such as a jugular paraganglioma or a meningioma in the jugular bulb or something else, you can see how that facial nerve is right in the way. And so there's this temptation to try to move it to be able to see things better. Of course, that causes at least a temporary praxia, but oftentimes a long-term partial facial nerve weakness. But there's 3 ways you can mobilize it. The first is a true posterior mobilization. And to do that, you're actually mobilizing the nerve from the brainstem all the way to the stylomastoid foramen, and you're moving it back. That's typically it's a transcochlear approach where you're removing all the bone around it, moving it posteriorly. That allows you really good access to the petrous apex and really almost all of the skull base. You can see things really well. That will result in a very significant, at least temporary facial nerve paresis, and most people will say it never recovers back to a Hausbrachten grade 1. You typically have some residual weakness even years after surgery. The second type is a anterior mobilization, and that's from your geniculate ganglion to the stylomastoid foramen, or even sometimes extratemporal, and you rotate that forward. That's part of the infratemporal fossa type B approach for jugular paraganglioma. That's to get access to the jugular foramen. That also devascularizes the facial nerve a bit, but it typically has a better recovery. And then the third one is something that's not commonly talked about, and I don't want to take credit for it. It's actually Dr. Driscoll in our practice who does this sometimes, and I learned from him. It's the inferior mobilization. It's just the vertical segment of the facial nerve. If you just mobilize the inferior half of that facial nerve, you can often get a lot better access to the jugular foramen. You're not devascularizing the nerve. And there are cases where you can move that nerve and actually have no weakness afterwards from just moving it a little bit. And just that little bit of those couple millimeters or whatever can sometimes help quite a bit for mobilizations. There's all these attachments into the facial nerve. Like, for example, the nerve to the stapedius, or the belly of the stapedius kind of comes back in that area. The blood vessel, the vasculature comes to the stylomastoid foramen artery. And it comes up and they invest on the backside, and particularly on the backside or on the second genua, there's a lot of attachments that go there, and you have to cut those sharply when you're elevating it out of the canal so you're not just yanking on the nerve too much. The key to mobilizing a nerve is extensively decompressing it, not just on 180, but really as far around it as you can get. So you're just leaving a little teeny bridge. And if you do that, you can move it with less trauma to the nerve when you start the actual mobilization.